So thanks everyone for being here. My name's James Petty. I'm from the Victorian Alcohol and Drug Association. And welcome to today's webinar on AOD 101, or an introduction to the AOD sector. I'd like to start by acknowledging the traditional owners of the varied lands on which we meet. I'm in Brunswick, near the Mary, the land of the Wurundjeri Willam. So I'd like to pay my respects to the elders of the Wurundjeri Willam, past, present and emerging, as well as the elders of the lands from which others are on and who are in this meeting. I'd also like to extend that respect to any Indigenous people here with us today and acknowledge that we're meeting on stolen land and that sovereignty of it was never ceded. This webinar is presented as part of the TriPeaks project. So TriPeaks is a collaboration between the Victorian Alcohol and Drug Association, VADA, pardon me, the Victorian Healthcare Association and the Centre for Excellence in Child and Family Welfare. The project is funded by the Victorian Government with the aim of promoting cross-sector collaboration. Now, before I hand off to my colleague Jane, who's going to introduce the speakers and the topic, I just wanted to say a little something about some polling that we're doing. So most TriPeaks webinars are made for all three sectors represented by each of the peaks. This one is a little different. So AOD 101 is designed more for those not working in the AOD sector. So we've set up a little poll to help us understand who is attending and what their level of knowledge is around the issues that we're talking about today. So that should be up on your screen now. So it's very quick. It's a 2-question poll that's just gauging your pre-webinar knowledge. If you could complete that, that would be great. Then after the webinar, a survey will appear on your browser. And you'll also receive an email tomorrow with a link to the survey. It's very quick too, only 4 questions, but we'd really appreciate it if you could complete both the poll and the survey. And the results are just for internal use, so the data will remain completely private. It's just to help us try and deliver better content and ensure that we're meeting the sector needs, the needs of each of the sectors. All right, so that's it from me. Thanks very much, Jane. Jane, you're on mute.
I know, the favourite saying, you're on mute.
Yeah.
I'm sorry, everyone. Well, good afternoon. My name is Jane Morton and I'm a colleague of James Petty's from the Victorian Alcohol and Drug Association. In today's session, I'll just give you a quick outline. We have 3 speakers. The first speaker is Mr. Moses Abadangelo, and he's from the Department of Health and Human Services. He is going to give you a broad overview of the AOD system, its structure, its funding, its workforce and so forth. And yeah, so he'll give you a good understanding of that. Secondly, we have Dr. Suzanne Nielsen, and she's going to talk to you about all things pharmacotherapy. Our third speaker is Casey Elmore, and she is the operations manager from the medically supervised injecting facility, and she's going to talk to you and give you a full overview of that. I also just want to remind you that this session is being recorded, and following the session today, it will in fact be put, well, it's more likely tomorrow or the day after, it will be made available on VADA's YouTube channel, which is called AOD TV. But you will all receive an email with a link to that recording. The other thing that I will just mention is hopefully after each speaker we will have some time for questions, and what I would ask you to do is to pop some questions into the chat box. Hopefully we'll be able to get through them all, but we do have quite a number of people online today, and so we will get through as many as we possibly can. All right, so I will introduce our first speaker, Moses Abadangelo. Moses has worked in the AOD sector since 1985 in roles within outreach, counselling, detox and therapeutic communities, as well as at the statewide telephone and online counselling services. As a long-time clinical leader and service manager, Moses has a passion for mentoring and supporting practitioners in the AOD sector to develop into leaders. He is keen to explore innovative ways of delivering services and ensuring they become more accessible to and co-designed by service users, and as a result, provide better integrated care. Moses has worked in DHHS since the beginning of 2018 and in the AOD Policy and Reform team, and more recently in the Office of the Chief Psychiatrists. Moses, I'll hand over to you.
Thank you, Jane. Now, I'm looking at a screen with the pre-webinar knowledge still up there, so I'm not sure if everybody else is still looking at that, but it may interfere with me trying to share my screen, I don't know. So can I start by also paying my respects to Aboriginal people across our state, both leaders past, present, and those that are emerging leaders. And, you know, I always feel a bit between and betwixt when we do these acknowledgements, because I really do look forward to a Victoria, or hopefully in Australia, where we are truly equal human beings, where we don't have to point out the other in such dramatic ways. So I look forward to that day. I hope it happens in my lifetime, but you know, the clock's ticking, so hopefully sooner rather than later. Let me share my screen. I'm coming to you today from my parents' dining room. I'm hoping you can now begin to see that. Jane, let me know if you can't. My father recently had a fall, so my mum's under instruction to not necessarily interrupt unless something dramatic happens. Can you let me know if you can see that, please, Jane?
We can't see it yet, Moses.
Here we go. Good. Can you see it now?
No.
Oh, that's annoying.
That's okay. Julia, would you like to...
Yeah, just 1 second.
Sure.
We have backups in the sense that we thought if there was any technological issues that we'd share it from our end.
I see. Okay. Now the very strange thing is I don't know how to unshare it because everything's disappeared.
That's okay. That's okay, Moses. We've got it up on the screen.
Excellent. Okay. So I've entitled this address really everything you wanted to know about the AOD sector and didn't know who to ask. And I suppose as one of the people who's been in the sector for a very, very, very long time, if you can do maths, you can work out how old I am. But I kind of volunteered to do this, one, because I'm very passionate about the sector and I think it plays an incredibly important role in health provision in the state. And two, because again, I look forward to a world where people who use drugs aren't necessarily as maligned and stigmatized as they are today. So it'll be a good day. Now, under normal circumstances, if we were meeting face to face, if you want to move to the second slide, I'd do an exercise I've called it emotional regulation, but it's probably emotional dysregulation. So I'll talk you through what the exercise would be, and then you can take that as a gift if you want to really stir some people if you're doing a presentation anytime soon. So what I'd normally get you to do is to stand up and pair off and face one another and hold hands. For a lot of people, that's going to be an awkward moment because they're holding hands with someone they don't really know or don't really want to be holding hands with. And obviously I would give people an option to opt out because physical touch is a bit more fraught now than it has been in the past, perhaps, both with COVID and with all of the Royal Commissions that have just run their course. So at this point in time, one of two chemicals is going to be starting to stream through your body. So you're either going to start feeling really anxious and therefore you're going to start feeling the adrenaline kicking in, which is, it's going to give you increased heart rate, respiration rate, maybe give you sweaty palms, all the rest of it. If you happen to have hit the jackpot and you're holding hands with someone who you would really love to be holding hands with, then perhaps a different substance is coursing through your veins now. It's called serotonin. It's known as the hug drug. It'll make you feel nice and warm and fuzzy. And all I can say is that what I would normally do now is to get people to look longingly into one another's eyes and just repeat these three words: I love you. And that gets a pretty strong reaction. And the reason I do that is historically I've done a lot of presentations in the past, often with the boys in blue beside me co-presenting. And often their opening remarks were, oh, you're a drug and alcohol worker, which drugs did you bring? So this morning, or this afternoon, sorry, I brought some serotonin and or adrenaline with me, and you have one or the other coursing around in your veins. So yeah, I apologize for the microphone rubbing on my shirt. I'll try to sit up more upright. Now, moving on to the drug and alcohol sector, you feel free to use that if it's appropriate. On slide 3, I've talked about our history and why that's important. So, you know, if we don't know where we've come from as a sector, and if we don't understand our history, we're damned to keep repeating the same mistakes we make. So when I joined the sector in the late 80s, mid to late 80s, the sector was far more abstinence-based than it is currently. It was not very trauma-informed. In fact, we talked more about people's ability to choose and not choose using drugs rather than their history kind of, in some ways, setting them up for a life of trying to manage and deal with the pain that often comes of trauma. The sector was run very strongly under all sorts of ideological frameworks. So I started work in a faith-based organisation, then I worked in a very secular organisation, and then I worked in an organisation that at the time had a very Eastern philosophical kind of bent. So, you know, lots of ideologies driving lots of ideas. The problem often with ideologies is that sooner or later an ideology paints you into a corner where you either have to say you can do or not do something based on your belief system. And I think a more pragmatic scientific approach to delivering health services is probably a more desirable position. So, you know, things like the Diagnostic Statistics Manual, or DSM-5, I think we're up to, weren't widely used in those days. And often we would see people in treatment, certainly for a drug at a time. So, you know, alcohol then was king, as it still is now, and then probably cannabis, and third cab on the rank was often heroin. And people would describe themselves in terms of being purists. So I'm a heroin user, I'm an alcohol drinker. And the notion of polydrug use, which has become much more common in our parlance these days, was pretty foreign in that context. So that's only 30 plus years ago. I think that's two things speaking. One is that people didn't think that their other drugs were necessarily lending into the problems they were experiencing with their drug of choice, or the poison of choice. We use lots of language around that. And also, I think because as a system, we were set up to deal with one thing at a time, and that's how we did it. So if you came to detox, we detoxed you off heroin or off alcohol or from cannabis, but we didn't tend to work across the spectrum so much. When we talked about talking therapies, counselling and such, we were talking to you about your heroin use or your alcohol use or your cannabis use, but very rarely did we kind of broach the topic of drug use as a way of coping with life and coping with things that may have been coming your way. So it was an interesting time. Things have changed pretty dramatically. And so there was a dichotomy in the sector, that which was self-help, 12 steps driven, AA, NA, and all the A's. Right, and then a more extreme kind of medical version. So at the time, there were 3 big specialist centres in the state that dealt with people from detox through to rehab and all the counselling and all the pharmacotherapies in between. And those centres were closed, and the sector was reformed at least the first time back in the mid-1990s. If we want to move on one more slide. So why did the sector change from that long-term kind of work? When I started in the sector, I could see clients for as long as I thought they needed my help. And that was a really wonderful thing on one level. You got to know a person very well. You got to start and understand their personal story and them in their own context, and then work with them long-term, putting a whole lot of strategies in place and dealing with all their psychosocial needs along the way. So generalist counselling was much more generalist than it is right now. The downside was that if you had a favourite client, you could kind of lean into that space and see them perhaps for a little longer than they really needed treatment, etc. So we reformed. We reformed fundamentally on the basis of a VAGO review of the AOD sector that said things like, and I'm quoting from the report, there was no assurance that the service system objectives of effective case management and continuity of care for clients with consistent high quality services are being achieved. So they're basically questioning whether or not the AOD sector was doing anything meaningful or good. Treatment services remain difficult for clients to access and navigate, and don't provide seamless pathways to other health and social supports. So we were tricky to get into, tricky to navigate, and tricky to get out of. and to link in with other service providers. And when we asked when the same questions were asked of service users and their carers, they came up with the same things. They complained about long waiting lists between weeks and many months, depending on the type of service they were trying to access, and that different parts of the sector didn't relate to one another. So those parts of the sector that were more 12 steps based didn't really speak to the medical part of the sector, and vice versa. And there was this divide between what was considered acceptable drug and alcohol treatment, what was drug and alcohol treatment, and what was considered changing dependency in some regards. If we want to go one more slide forward, please. So when the sector was reformed, it was the work started in 2014-15 or 13-14, and it started with adult community-based treatment services. So that is all the adult service side of the sector. So that's 16 and above, that was in the community that wasn't bed-based. And those many services, and there was a whole lot of nuanced, quite boutique kind of services at the time, were truncated and distilled down to 6 different services. So intake and assessment. So intake being like a triage system where we work through whether or not someone actually has a drug or alcohol dependency. Assessment, then going through and taking their whole story and understanding them in their own context. Care recovery coordination, which is like a role that holds a person's hand throughout the system, helps them traverse the different types of treatment that they might need in order to get a good outcome. Counselling, which I don't think needs much explanation. Non-residential withdrawal, and then therapeutic day rehab. So these were all community-based services, and it excluded all the bed-based services, so withdrawal and rehabilitation. And it also excluded all the youth-based, Aboriginal-based, and specialist statewide services, like the telephone counselling services, like the women's alcohol drug services based at the Royal Women's Hospital, and several others. When we reformed that part of the sector was reformed around drug treatment activity funding. So rather than giving services a wad of money and saying deliver X amount of treatment, treatment was then based on an average number of sessions that a client attended, and services were paid on the basis of that. It wasn't too dissimilar, but it meant that treatments could be prioritised and complexity could be built into the system. So that, for example, if someone was a forensic client with Aboriginal heritage, that attracted a higher paying rate than a standard care client who might come in for 3 or 4 sessions of counselling. And so there was an understanding of complexity built into the system. It's not a perfect system, it certainly needs some review, but that was how it went. And the rest of the system, so youth, Aboriginal, drug and alcohol services, and some of those statewide services remained as episodes of care funded services that just got that wad of money at the start of the financial year and were expected to deliver certain numbers of clinical episodes throughout the year. Over to the next slide. So some of the underpinnings of the AOD sector, and it's important to understand that we talk about the sector as working with harm minimisation principles. That really accepts the reality that many people use drugs. Many people will continue to use drugs whether or not regardless of whether they get treatment and regardless of whether that treatment's evidence-based and clinically sound. So harm minimisation looks at 3 aspects. Supply reduction, so that's all of the police and legal kind of boundaries around a country like Australia, so customs, all the rest of it. Demand reduction, which is trying to look at why people use drugs and trying to inform them in a way that helps them to make more informed choices about whether or not they're going to use more or different or continue to use drugs. And then harm reduction, which accepts the fact that people might continue to use drugs, and therefore we try to educate them how to use those drugs in the least damaging ways, both to their physical health and psychological health and well-being, and some of the social and legal impacts that drug use might have on them. Often, harm reduction has been conceived as a thing that happens before or in the early parts of treatment. And I think that's a misunderstanding of harm reduction. I think harm reduction or harm minimisation happens the whole way through someone's treatment journey and beyond. It can be simple things like teaching our teenagers to have water whilst to include water in their regime of drinking if they're going to drink heavily, and make sure that they remain well hydrated. I heard a great harm reduction strategy where someone was encouraged to put a $10 note inside their shoe, so at the end of a night they would have the money to pay for a taxi to get home. It's a great harm minimisation strategy that's not directly related to the drug use, but at the consequences of drug use potentially. And it also accepts the fact that motivation to change is a thing that waxes and wanes over time, and that drug use is a chronic relapsing condition for many, many people. So the notion of complete recovery or complete abstinence is not one that we see really well represented in literature. And so the notion that people might continue to use... could you say it again? Sorry, that's Siri chiming in on the conversation. I don't know what I said that woke her up. Anyway, what was I saying? So yeah, harm reduction being right across that spectrum. So for example, I worked in a service where people would come for their counselling session and they would go downstairs to see our GP to look at all their pharmacotherapy needs and make sure that they had a current script and that they were up to date with their payments. And then on the way out the door, they might collect clean needles and condoms to make sure that they stayed safe if they were going to continue to use drugs as along the way to changing the way that drugs featured in their lives. So there's no presumption about abstinence, nor is there a despairing sense of no one will ever give up drugs. So it's somewhere in the middle, and it works with the realities that are presented to a person who's the person providing treatment. So hospitals are based in hospital-based services, so they're a department within a hospital, sometimes in community health-based services. Sometimes they're based in regional health services, small regional hospitals. Shepparton, for example, has 2 detox beds. La Trobe Regional Hospital has 2 detox beds and a clinical liaison nurse, etc. And sometimes they're standalone non-government organisation, non-profit organisations like an Odyssey House or a Windana Rehab. One of the things that probably should be said is the place of peer-delivered support and lived experience within drug and alcohol services. So increasingly, we are seeing a change similar to the mental health sector, where people with lived experience have a really crucial role in providing support for people in the midst of treatment. They can be an image of hope for someone who can't hold that for themselves. They can be a person who helps translate all of the jargon of our sector and the expectations of our sector into practical day-to-day ways of operating and managing. They can provide an emotional shoulder to cry on, or just to be a support, a voice to be a sounding board. But in all of those ways, I think that peer and lived experience in the context of treatment is a really important and growing thing in our sector, and I'm really pleased to see that starting to happen. So what does our sector do? On an annual basis, that's the next slide. On an annual basis, we see around 30-odd thousand clients. I think it's climbed up to about 40,000 in the last statistics, but I didn't update this because I hadn't had a clear look, so I didn't want to mislead you. But I know for a fact that 2017, 18, 19, it was about 31,000. That's in comparison to the mental health sector, who see about 76,000. So we're about 1/10 of the size of the mental health sector, and we see about half the number. So that shows you that it's a very busy, very productive sector. 63% of those people that are seen for treatment live in metropolitan areas of Melbourne. So that's from the far out west, Sydenham kind of suburbs, way out to the way out east, Frankston, etc., down the peninsula. 2/3 of those clients are male. Those numbers vary depending on the treatment type that you're talking about. So in the telephone and online counselling space, we see almost a reverse of those numbers. So 2/3 are female. It's debated, but you could argue that about 80% of our clients who come to see a drug and alcohol clinician in one form or another have a mental health related issue. Then that's not necessarily things like major depression, but it can be things as simple as anxiety and depression. Homelessness features pretty largely in some of our service users, as do considerations around family violence. Obviously, alcohol fuels a whole lot of family violence, so alcohol plays really largely in that space, but so do some other drugs, not so much the depressant drugs, but some of the others, ice as an example. Alcohol is still the most commonly used drug of concern, and then that's followed by amphetamines and amphetamine type substances, cannabis, and then a whole lot of polydrug use. The AOD workforce is made up of about 1,700 people across Victoria, across about 100 agencies. And as far as pharmacotherapy goes, so I know Susie's speaking about that soon, there's about 14,000 plus clients in that space. That number fluctuates slightly, but it's sat around the 14,000 mark for the last decade or so. And as far as the telephone and online help services go, we get about 2 million calls and hits on those services, about 90,000 telephone calls, and the rest are hits on websites over a year. About 14,000 of those come from family members seeking information and support. So that's peer-driven services run by people who are carers of people with lived experience of drug and alcohol use. Every year we distribute about 10.5 million needles. That number's exponentially growing, particularly since the advent of COVID. So there's been a real spike in the demand for clean injecting equipment. And certainly over the last 4 or 5 years, a huge increase in the funding available for the sector and the diversity of the services that we can provide. If you want to flick to the next slide, please. So this diagram really tries to explain in a flow chart how people can access services. So you'll notice at the top of the diagram, it talks about the entry points. So Direct Line being one of them, and then the intake and assessment providers being another point. Clearly, if people have ongoing relationships with a service provider, they can ring them directly and curtail all of this. But generally speaking, as far as regional drug and alcohol services go, these are the two ways that people will get in, through Direct Line and then to the intake providers, or through the intake providers into drug and alcohol treatment. We talk about centralised intake in the AOD sector, and to translate that, what that means is a regionalised approach to intake. So there's a regional intake provider or two in each of the health areas across the state. So there's 17 of those. So there's 1 or 2 agencies, generally 2, in each of those 17 areas that can provide intake and assessment services. And then all treatment providers are able to do a comprehensive AOD assessment. And that's using a standardised tool. And then they are able to access all of those services there in the green, all the community-based services, and some of those population-specific services, like the youth-based or the Aboriginal-based services, are specific services such as Galliamble or so Galliamble for Aboriginal services, or YSAS for youth services, and there are other examples. And then there's a series of specialist statewide services that are able to be accessed either by telephone or online for people needing particular needs. So I mentioned before WADS, which is the Women's Alcohol and Other Drug Service, or the AID Clinical Advisory Service. So that's a service set up if you needed advice on drug and alcohol issues, didn't know who to ask, you could ring a 1-800 number, speak to an addiction medicine specialist about the issue that you're having, and they'd provide you expert advice around a way forward in terms of that drug and alcohol treatment. Much of that advice that they provide is around pharmacotherapy, but they do provide advice around other issues as well. So all that change has happened. The sector is as it is. Obviously, there are still issues that remain. So next slide, please. I think it's true to say that there was previous serious underinvestment in the AOD sector, and over the last 4 or 5 years, there's been a 65% increase. So we're up to about 243 million across the AOD sector. and some of the ancillary bits and pieces, but there's a long way to go. I know that there was a report put out some decade ago now about how big the drug and alcohol sector should be, and about a decade ago, the answer was roughly double the size that it was then. So now it's about 1 1/3 the size that it was then. So still a long way to go. The integration of mental health into drug and alcohol treatment is still less than desirable. So people come to drug and alcohol with mental health issues. People go to mental health services with drug and alcohol issues, and they tend to hit a wall. Part of the reason for going to the office of the chief psychiatrist was to fly the AOD flag in a pretty central part of the mental health space and see if we couldn't affect some change there. So that's part of the reason for my move, and also wanted to learn some new stuff. Poor data systems. So Vago recommended a complete rehash of the data collection systems that underpin the drug and alcohol sector. And so a new system was put in place 2 to 3 years ago now called the Victorian Alcohol and Drug Collection, the VADC. The beauty of a system like that is that over time we can start to see real trends and real changes in the drug and alcohol system, changes in the way people are using drugs, what drugs they're using, how long they're staying in treatment, etc., etc. And over time, we'll start to build into that system some outcome measures, so we can see if they do this kind of treatment, what are the likely outcomes. So they do a 10-day detox, and then they go to a rehab program. What are the likely outcomes? They do 6 weeks, 6 months of counselling. What are the likely outcomes? And we can start to see where we can focus our attention and our resources as a sector. Some of the real challenges are that there's changing historical practice, and some clinical practice remains unchallenged. And, you know, having been a clinician and having supervised clinicians over many years, people tend to have their favourite modality and they tend to stick to it. You know, if something works, why change? I think as a sector, we need to change that paradigm and say, well, if something works, maybe there's something better, and be looking for quality improvement processes in the way that we interact with our clients. And then there are significant workforce shortages across the sector, shortages of nurses, qualified psychs, social workers, and AOD workers broadly, and that's particularly so in regional and rural Victoria. You know, some people say, you know, why change something and constantly change things? And my answer to that is that as a sector, our whole reason for being is to spruik change. You know, whether that's changing the way that I use drugs from really harmful, problematic drug use to less harmful to my health and well-being, or whether that's stopping drugs altogether, or rehashing my relationships, or looking at my social networks. We spruik change every day. So it really is a question of whether the medicine is good for the doctor, I think, and in this case, the sector. So if you can move on to the next slide. So some of the players in the sector include the funded non-government sector, funded services that tend to arrange themselves in consortia. So that's just another fancy word for partnerships. And in those consortia, there's often a consortia lead who are the primary contact for the department to interact with around meeting key performance indicators and making sure that they do the work that they're contracted to do. Obviously, service users and their carers, the department, often seen as the bad guy in this picture, but I think the department has a huge stake in seeing the service sector improve, and then the broader Victorian community. There are the non-funded private providers and NGOs, and there's a lot of work afoot to regulate and bring them into the fold, so to speak, so that their work is more evidence-based, so that there are some overarching standards that they need to meet and adhere to in order to provide service and call themselves a drug and alcohol service provider. And it kind of begs the question really of whether we're one sector or a whole lot of sectors trying to work together. And what our metaphor for work is. So, you know, I've worked in the drug and alcohol sector, as you know, for a very long time. If we perceive drug and alcohol use as a monster to be tamed, then you can understand that the way we arrange ourselves as a sector is to quell and cage the monster. But if we say that anybody's behaviour can be changed if they are supported. Then the way that, so that metaphor is very different from treating a monster. Then the way that we arrange ourselves can be different too. And I think over time, the AOD sector has become and is becoming more compassionate towards our service users. You know, for example, 20 years ago, when I was counselling and someone was late to the point of arriving 15 minutes before the end of an appointment, I would just book them another appointment. I think more contemporary practice might be, well, you've arrived, well done. Let's give you 15 minutes. If the next client doesn't show, let's give you your full hour. Well done for getting here. So it's about acknowledging people's strength rather than focusing on their weakness, acknowledging the effort rather than focusing too much on what is perceived as being a failing. And I think over time that change is a really good thing. And the way that we perceive ourselves as a drug and alcohol sector in working with other sectors, family violence, homelessness, mental health, health and hospitals, community health, primary health, doctors, GPs, is really important in terms of the kind of work that we can provide and the kind of support that we can provide our clients. So I'll stop there and maybe take any questions that might be coming up in the chat, and hope that that actually gave you a nice broad overview of the sector.
Yeah. Thank you, Moses, much appreciated. And this is the beginning. You have extraordinary knowledge of the system, having been in it for so long. So yes, it's wonderful to see. There are several questions. Do you want me to read some bits, or can you, well, maybe we've only got a couple of minutes.
Yep.
But, oh, hang on, I'm actually reading the, okay, there's someone who's asking about the sector not being particularly trauma informed. And I guess the question that has come out of that is, are there any plans to acknowledge the presence of trauma in both AOD and so-called mental health conditions and provide trauma-informed care?
Yep, so there's been a lot of change probably over the last 3 or 4 years. In some services, often led by people who have psychological training, trauma-informed care has become pretty much the status quo. So, you know, I'm aware of services in the inner east run through community health services where their leadership have rolled out trauma-informed training right across their staffing bodies in their AOD teams. And so I think they're doing a much improved job to what we were doing 4 or 5 years ago. That's not to say that that's uniform across the AOD sector and there isn't a lot more work to do. A few years ago, I was part of a thing called the Change Agent Network, which was working with emerging leadership in the AOD sector, and trauma-informed care was one of the things that we started to roll out then, and it was hugely embraced in the AOD sector. I think we ran a forum and close to 200 people turned up for some specific training with some people from Melbourne Uni who work in this space as their core business, so to speak. So, I guess there's a difference between being trauma informed and doing trauma work. And you know, I don't think we want to lean into that space because working with drug and alcohol issues can be complex enough. But absolutely, I think there is a need to continue that work and to generalise that across the sector and make sure that all of our staff are able to understand the impacts of trauma on a person's well-being and their future prospects, as well as the terrible white noise that can be when they're sitting there trying to work through really difficult issues with a counsellor or in a rehab program or in a detox program. So yeah, thank you for the question. I think it's something that we're working on.
Yeah, look, we've just got one more minute. There is another question here from Joseph, which I may have answered partly. He's wanting to know about dual diagnosis services. And given the evidence and demand, what's happening with that? And I guess a lot of that is hopefully coming out of the Royal Commission, isn't it, Moses?
I think the recognition that dual diagnosis is not a separate thing, but it's almost the game. It's not a side game, particularly given the numbers that I quoted. And I hold to the 80% of people who come for drug and alcohol treatment had probably got a mental health issue in the background.
Yeah.
Or in the foreground. I mean, I guess
Yeah.
it depends on how you choose to perceive that. Then I think dual diagnosis is just the way we should be going. And this notion of people arriving and not arriving at the wrong door is really important. So AOD-informed mental health workers and mental health-informed AOD workers has been a conversation that's gone on for probably more than a decade now. I think there'll be a renewed energy, thanks to the Royal Commission, around retraining of both workforces to the point where we can work together.
Yeah.
And hence why I've gone to the enemy, so to speak.
Yeah, okay. There are a couple of other questions, and they're both really, really good questions, but I'm sorry, we are out of time. I mean, if we have, are you hanging around, Moses?
I can hang around, yeah.
Yeah, if we get time at the end, then we can certainly come back to them. All right, thank you, Moses.
Pleasure.
Much appreciated. Our second speaker is Dr. Suzanne Nielsen. Susie is an associate professor and is the Deputy Director of the Monash Addiction Research Centre in Melbourne and an NHMRC Career Development Fellow. She has published over 110 scientific publications and given over 150 national and international conference presentations. Her research has led to a greater understanding of how to identify and respond to prescription and over-the-counter drug-related problems. She has informed legislative change in Australia to reduce pharmaceutical drug harm, e.g. rescheduling of codeine and alprazolam, and expanded overdose prevention with naloxone in primary care settings, and informed clinical guidelines on the use of opioid agonist treatment for prescribed opioids dependence. Her current research focuses on understanding how to improve identification of prescribed opioid use disorder with the aim of reducing risks related to prescribed opioid use through evidence-based treatment and prevention. Welcome, Susie. You're on mute, Susie.
Sorry, I couldn't get the button to unmute myself. Great, thank you. So my slides are showing up there okay for everyone?
Yes.
Yep.
Yes, they are.
So I'm going to give an overview of opioid pharmacotherapy treatment for opioid dependence. In that relatively dense bio, I don't think I have mentioned that I'm a pharmacist by training, and I've worked for many years providing pharmacotherapy treatment, methadone and buprenorphine, in both community pharmacies and also specialist drug and alcohol treatment settings. And I continue to do a lot of research in this area. It's an area that's very close to my heart. So just to give a bit of an overview of some of the treatment options for opioid dependence, there's a range of different approaches and many of them can often be combined. But just to give an idea of where pharmacotherapy sits, there's, I guess, if you're going to consider the options, there's kind of detoxification or taper, short-term, sort of 1 to 2 weeks where people are reduced off opioids, usually with sort of symptomatic or other medications in a relatively short space of time. That is generally fairly successful in the short term, but the long-term outcomes for that are generally not good. And because of a really significant increase in someone's overdose risk after a short-term taper, that's generally not recommended as a standalone approach to treatment. There's also a range of psychosocial treatments, groups and CBT, NA, all those kinds of approaches. They can often work really in a very complementary way with other approaches. And one of those approaches that they can be quite complementary with is things like longer term pharmacotherapy treatments, opioid agonist treatment, methadone and buprenorphine, which I'm going to predominantly talk about today. In terms of people who have moderate to severe opioid use disorders or dependence, these have some of the strongest evidence in terms of not only long-term outcomes around substance use, but also in keeping people alive. There are other options, lots of other options, and I haven't covered the whole spectrum of treatment options, but just some of the common ones to give you a sense where opioid agonist treatment fits. There's also an antagonist, naltrexone, and I'll touch on that very briefly. So in terms of acronyms, I feel like this field is one that's absolutely filled with acronyms, and if you're going to be sort of, I guess, reaching in or like interacting with the AOD field, you might hear many of these different acronyms, which essentially all mean very similar things, but I thought it was worth actually explaining what they are, because it can become quite confusing. So I use the term opioid agonist treatment. I think that's considered to be one of the least stigmatizing terms in terms of when we're talking about these medications for opioid dependence. You will hear opioid substitution treatment or opioid replacement therapy, OST or ORT, quite commonly. They tend to be less used these days, and I think the reason for that is because they tend to perpetuate this stigmatizing perception that you're substituting or replacing one drug for another and that it's not treatment. And so for that reason, there has been a bit of a shift away from those terms in recent years. And I've just popped up, there's a reference in the bottom, and this Language Matters resource, which was developed by Neura and NADA around sort of using less stigmatizing language. And you can see down the bottom there, I've just highlighted, I'm not sure if you can see if the font's too small, that this idea of replacing one drug for another tends to be something that we're trying to move away from. And so pharmacotherapy is treatment, or pharmacotherapy treatment is preferred. You'll also hear medication-assisted treatment for opioid dependence. We have national guidelines that are called MATOD guidelines around opioid dependence treatment, ODT. So there's a whole range of things which are essentially can all be used interchangeably. But just to have, I guess, in mind that, you know, you'll hear different terms and that some of these terms can carry some baggage for some people. So when we're talking about opioid agonist treatments, we're mainly talking about two different medicines in Australia, methadone and buprenorphine. We have methadone available as an oral liquid. We have buprenorphine sublingual films. And we've also relatively recently had added into our options that are available a long-acting buprenorphine injection. And that long-acting buprenorphine injection can be given in either weekly or monthly doses. So I'll talk about that a little bit. Someone's asked if we can give the link for the Language Matters. If you literally Google Language Matters and NUA, N-U-A-A, you'll find it, but I can post it when I get to the end. Let's see if my slides are going to advance. There we go. I know that people are coming from really different backgrounds, but I just wanted to, at a very high level, kind of touch on the difference between some of these medicines. So we've got here methadone. It's considered to be a full opioid agonist. What that means is as you keep increasing the dose, you keep increasing the response. That's good when you're looking at in a certain range. For example, if you're looking at increasing a dose to respond to pain, and if the pain hasn't been treated, you can increase the dose and get a greater response. It's not so good when we look at some of the side effects. So for example, with respiratory depression, which is a common side effect of opioids, there is a point at which you increase the dose of either methadone, heroin or morphine, and you will actually suppress someone's respiration to the point that they will stop breathing enough to be able to get enough oxygen circulating around their body. And that's the primary way in which opioids cause mortality, is through stopping people breathing. A partial opioid agonist, which is buprenorphine, has an opioid type effect. So it has an effect similar to the opioids that people might be taking when they develop a drug sort of use disorder. So similar to codeine, morphine, oxycodone, heroin, but it's not quite as strong, and there's a ceiling to its effect. So as you keep increasing the dose, you don't keep increasing the response. It hits this ceiling, and it doesn't tend to cause the same levels of respiratory depression or sedation, or things like euphoria as well tend to be a little lower with partial agonists like buprenorphine. And then the third kind of drug that acts at the opioid receptor is called an antagonist. And this is something that binds at a receptor, doesn't have any activity, but it stops other things binding. So if you can imagine it like a blocker. So if you've got a lot of naltrexone in your body, other drugs won't have an effect, other opioid drugs. So if you have naltrexone and you use heroin, it won't work. But they also don't tend to have any of those positive opioid-like effects that can be reinforcing. And so we often find that people don't feel particularly good when they're using naltrexone. I mean, it varies. Some people find that it works for them and others don't. But we also find that people don't tend to keep taking it. It has what's called low retention in treatment. People don't keep using it and then it doesn't work. So we do find with these drugs that have either a partial or full agonist effect, because it creates that opioid-like effect, it does tend to retain people in treatment better. That's all I'm going to talk about pharmacology really today, but I just wanted to give a bit of an idea of the differences. So in terms of the principles of opioid agonist treatment, the idea is that you provide somebody with a regular known dose of a legal opioid in a fairly structured way. And what this does is it means that people aren't experiencing withdrawal symptoms every day. And if you're not familiar with what opioid withdrawal feels like, it can make people feel very unwell. It's like having a very bad case of the flu. And when people are using regular doses of short-acting opioids like heroin or oxycodone, often they'll be cycling in and out of withdrawal on and off all day, and it's quite disruptive. It makes it very hard to sleep. People feel very unwell and they get a lot of craving. So if you're able to provide a regular dose and an oral or sublingual dose, for example, of a known opioid, that's able to remove somebody sort of feeling those uncomfortable withdrawal symptoms, and also reduce the craving that people might feel for opioids. So it really provides sort of very stabilizing or normalizing feeling for people. And if you talk to people who have been using other opioids, for example, or like heroin for a long time, often what they'll describe when they're using opioid agonist treatment isn't that they feel, people don't feel high, they don't get a real rush from it. They just report that they feel normal, they don't feel sick, and you're able to focus on other things. And part of that is being able to engage in other kinds of treatment, in psychological treatments, and being able to engage in work and caring for children and doing all those other things that you find a little bit harder to do when you're constantly feeling sick and in withdrawal. So it is really important in terms of providing, I guess, a backbone to help people engage in treatment, and often to be able to do many of the other things that are important in a person's recovery, like being able to work through some of those issues around mental health and trauma and all of the other things that might contribute to a person's presentation. So we know in terms of the many, like hundreds and hundreds of really large clinical trials that have looked at these medicines, that they're very effective for a range of things. They're very effective for keeping people alive, and there's a profound reduction in mortality when people are in treatment with opioid agonist treatments compared to when people are out of treatment. That's not only mortality due to opioids or things like overdose, it's all-cause mortality. So mortality or death from any cause is reduced when people are in opioid treatment relative to out of opioid treatment, if they have an opioid use disorder or opioid dependence. When we look at things like bloodborne virus transmission and other harm relating to injection, that's greatly reduced by being in treatment. There is a reduction in crime or illegal activities and people's contact with the justice system, and improved health from a whole range of measures. And some of that is from being able to have greater contact with the health system in general. And often when people come into treatment, it's not just about providing methadone or buprenorphine. Often it comes with connections to dental care, other health care, a whole range of benefits from being engaged in the healthcare system in general. And these benefits are not only for the individual, but often for their families and for the community more broadly. So just to talk a little bit more about methadone, many people have heard of methadone. It's been around for a long time. It was really upscaled in the 1990s when we had HIV becoming a very prominent concern. It's what I described before as a full opioid agonist, so it has effects that are similar to other opioids like morphine and heroin, but it has a very long period that it's active for. So people who are stable on a methadone dose only need to have a once daily dose. It doesn't cause, as I mentioned before, a rush or a high. It really causes people to feel not in withdrawal and, I guess, in inverted commas, normal. It does have some side effects. It can depress respiration. It can cause sedation. When somebody's on a stable dose, they shouldn't feel sedated all the time, but you often will find that while people are getting onto the right dose, that can be something that people might experience. And relative to buprenorphine, the other drug that I'm going to talk about, people often do report they do feel more cognitive effects, sort of, often described as feeling a bit cloudier in their thinking. It is a long-acting medicine, and the dosing is really critical. There is a risk of overdose if the dose isn't right. And then you'll see that when people are in methadone treatment, there are a lot of safeguards around having supervised dosing and regular reviews. to make sure that we don't have people sort of ending up having toxic effects from methadone. And that's the reason that we do have so much structure around this treatment. There are really good outcomes, and generally longer term outcomes occur with longer term treatment. So for example, often if someone is starting on treatment, they'll think, oh, I just need to be on this for a couple of weeks and then I'm going to be able to jump off it. What we know from the research is that if people are in treatment for at least 12 months, they have a lot greater likelihood of staying off opioids when they come off methadone compared to those shorter term treatment episodes. And we also know to have good outcomes that typically people need to have a higher dose of between about 60 and 100 milligrams. Now, sometimes a patient will have a preference to stay on a lower dose for a range of reasons, and working within sort of a harm reduction framework, if that's the patient's preference, that's fine. But if you are looking to try and, if the patient's goal is to reduce opioid use, then typically you'll need to be looking at those higher doses. But again, there is some flexibility to work with what works for the person in treatment. Buprenorphine is the other main alternative. It's been traditionally provided originally as a sublingual tablet and now more commonly as a sublingual film, and you can see that in the right hand side there. It looks a little bit like those, or it feels a little bit like those Listerine strips if you've ever seen those. It goes under the tongue and dissolves quite quickly. Again, it's given in a supervised framework. It's what's called a partial agonist, so I described that before. So it doesn't have as strong an opioid effect as a full opioid agonist, and it does have a sort of maximum effect that it'll reach. And when you keep increasing the dose, you actually don't keep increasing the response. It also seems like with buprenorphine that people experience less severe withdrawal symptoms. It can be a little bit easier to get off. I guess that can be a double-edged sword. It's good if somebody wants to get out of treatment to be able to reduce off it more easily, but it does seem that people tend to stay in treatment longer with methadone, and methadone is often considered to have maybe some slight advantages in terms of retention in treatment. But when we look at effective doses of buprenorphine compared to effective doses of methadone, they're actually both relatively comparable. One isn't necessarily more effective than the other. There is considered to be a better safety profile with buprenorphine, as mentioned, less sedation, less respiratory depression. This can make it a good option for people who might be thinking about returning to school or working or parenting, and where that sedation or cognitive sort of slowing down, can be a little bit of a barrier. On the flip side, for example, I've worked with many patients who have really significant trauma in their histories, and sometimes that level of clear-headedness isn't something that somebody might be in a point in their life that they are seeking, and it can be very difficult to to have a lot of memories and things coming back. So again, it's something that's really around an individual's goals and what works for them. One of the benefits around buprenorphine, and it's partly related to this sort of partial agonist effect, is that you can have alternate day dosing or even 3 times a week dosing. So you can actually, once someone's on a stable dose of buprenorphine, they can have a double dose and they can go in every 2nd day, or they could have a triple dose and go in every 3rd day. That really reduces the burden of these highly supervised treatments on people who might be trying to balance a range of commitments. So that's one sort of aspect of buprenorphine that can provide flexibility. You can also have, and reflecting that safety profile, more unsupervised doses where people are able to take medication home and not have to go into the pharmacy every day. So that also provides more flexibility. So with buprenorphine, for someone who has been in treatment for a long time and is considered to be sort of low risk or very stable, you can actually have medication dispensed as infrequently as once a month. So that again really helps if people have a lot of other commitments in their life, employment, trying to balance a whole range of things. We also have these new injectable buprenorphines, long-acting injectable buprenorphine, where people can have a once a week or once a month dose. So again, that provides a lot more flexibility. Now, I've talked predominantly, and a lot of the evidence for these treatments is around heroin dependence, but we do have in Australia a significant number of people who seek opioid agonist treatments, so methadone or buprenorphine, for prescription opioid dependence. And so I actually ended up doing a lot of work around looking at the evidence for how effective these treatments, methadone and buprenorphine, are for people who develop dependence to prescription pain medicines. And actually, it seems like most of the evidence translates quite well. Methadone and buprenorphine are equally effective and very effective for reducing opioid use and retaining people in treatment for when treatment has developed with prescription opioid dependence. So that's good to know that essentially the evidence that we have still seems to apply irrespective of the opioid. We also know that both of these options are quite good for people who have both pain and opioid dependence, and quite often that's a real concern for people who've developed opioid use disorder with their pain medicine. Is like, well, what's going to happen if I get transferred off my oxycodone or off my morphine onto one of these treatments? What's going to happen to my pain? And while the evidence base is still developing, it does seem to suggest that most people will have either no worsening or an improvement in their pain, and often that's just because of a stabilisation around the opioid use patterns. We also know, again, with people who have developed dependence to prescription opioids, just as we've seen with dependence with heroin, that maintenance treatment, long-term treatments have better outcomes compared with short-term treatments. And again, short-term treatments aren't recommended in isolation. There are some really important barriers to these treatments for people who use prescription opioids and people who use opioids in general. And probably one of the biggest ones is stigma and people's perceptions around these treatments. Often methadone in particular is something that many people will have associations with and kind of see that that might not be something that they see for them. We often will see reporting in the media that's not very positive about these treatments, and that is something we really need to work very hard to change. And I think a lot of that stigma is around this kind of concept that, you know, you're just replacing one drug for another. You know, we're giving people who use drugs, and I don't think that that's accurate, and I think that really undersells the efficacy and the benefits of these treatments. But it is something that we need to be aware of and be aware that that people who are considering these treatments might be experiencing. So in terms of access to pharmacotherapy, this is one thing that really varies depending on what state you're in. There are lots of different treatment systems in Australia. I'm going to focus on the Victorian treatment system, but do be aware that if you're working in different states of Australia, that you might come across different systems. But in Victoria, we have really a primary care focused system. So most people have a primary care prescriber and they're dosed in a community pharmacy. And there is a cost for daily dosing, which I will speak to. We have these, with these oral and sublingual forms, so the methadone and sublingual buprenorphine, people need to attend generally every day at the community pharmacy when they're first in treatment, but ultimately there are supervised doses, unsupervised doses that can be prescribed if people have been in treatment for a sufficient amount of time, and the assessment of the safety and appropriateness is in favour of unsupervised dosing as well. But that daily attendance at a pharmacy can be quite challenging for people, particularly people, again, balancing those multiple commitments of work or family, and it is something to be aware of. That is removed to some degree by these new long-acting injectable formulations of buprenorphine. These are administered by a healthcare professional, so they're never provided to the patient. They are actually an extremely high dose in those formulations, and they do need to be administered correctly. So they're usually administered by a healthcare professional. Typically, that's going to be a nurse or a doctor, but there is some talk of pharmacists maybe administering it in the future, but it is never given directly to the patient. So the patient will need to attend somewhere to have that administered once a week or once a month. In terms of some of the issues around pharmacotherapy that both providers and patients face, we often see that in terms of the cost, it is an expensive program. So most medicines in Australia are subsidised by the Pharmaceutical Benefit Scheme in a way that you generally would pay once a month, $6, and once you've got 52 scripts in a year, if you're on a concession card, once you have 52 scripts in a year, that will become free. If you don't have a concession card, you'll pay a higher price, but after around 52 scripts, that'll become $6. So there's a cap on how much you pay for medicines, and it's subsidised. For methadone and buprenorphine, that's not in place, and rather than $6 a month, we often see people are paying, you know, $5 to $8 a day for a dose, and that's quite a large proportion of people's money, particularly if they're on something like Newstart. And that debt can actually also be really impactful in terms of putting a strain on relationships between people who are in treatment, and sort of the pharmacy who have to every day ask for that payment. So that is a real barrier, and something that there's been a lot of advocacy around getting a more equitable way for AOD treatment and methadone and buprenorphine to provide that's more similar to other chronic health conditions. In terms of attendance requirements, as I've touched on, it can be really challenging to go every day to a pharmacy to collect your dose. Sometimes we see that play out as diversion, where people will try and not take the dose in the pharmacy so that they can take that home, or sharing of takeaways where people try and support the needs of their peers who might be in withdrawal. There are some safety issues around that, but I think when we see diversion, we need to understand it as being in the context of often when we see diversion, it's a sign that current treatment's not sufficient. Either enough people can't get into it, or people can't manage with the way it's being provided. And then the final key issue that I've already touched on is stigma. And we have a lot of issues around attitudes towards these treatments, and also within our healthcare providers, attitudes that healthcare providers might show towards patients that can be quite stigmatizing. And we know people in opioid treatment often already feel quite judged. I just wanted to touch on a couple of really practical aspects. I know that this is a seminar for people who are not necessarily working directly in the AOD field, but if you're working with patients, it's worth being aware of some of the logistical challenges that they might be working through if they're trying to access this treatment. So I've already touched on the requirement to attend a pharmacy every day. That can be a challenge. It can also be a challenge depending on where you are in Victoria to find a prescriber in a pharmacy. Some geographical areas are really well served. Others, there really aren't very many prescribers, and some people do have to travel quite a long way to find a prescriber. You are able to call either Direct Line or also PAMS, the Pharmaco Advocacy and Mediation Service, are two places where you can get details of where you might be able to find a prescriber, but it can be a challenge. And particularly if people have kind of burnt their bridges with a debt, finding a new pharmacy can be challenging as well. The payment, often upfront, people need to come up with a couple of weeks payment for a pharmacy to start them. So again, that can be a financial barrier to starting treatment. You need to have identification, and that can be a challenge, actually having enough points of ID to be able to get your script and see the doctor to get a permit. The doctor can't just prescribe it on the spot. They do need to apply for a permit from the health department. So there can be a few steps in getting somebody started. Often it can be same day, although we do find that that's not always the case. There is a need for a prescription, and particularly in the time of COVID, it's taken a little bit more of a logistical challenge to be able to get the prescription to the pharmacy. And when we have people doing telemedicine, we've got e-prescriptions happening now, but it has been something to consider. And often pharmacies will have, and prescribers as well, will have contracts around behaviour and other things that are expected in treatment. So that's some of the processes around starting treatment. The other thing I was asked to speak to very briefly was just to give a little bit of a brief overview about SafeScript, which is a real-time prescription monitoring system that has been implemented in Victoria, and you might hear about this. It's an online system that provides access to information about any monitored medicines that somebody's received in the last 3 months. And you can see on the right-hand side of the screen there all of the medicines that are covered by this system. So we have a whole range of medicines, either for pain or for opioid agonist treatment. So you can see our common kind of opioids. There's also a whole range of medicines for anxiety or sleep. So all of the benzodiazepines, and also zolpidem and zopiclone, which are used for sleep. And then also some of our prescription stimulants like dexamphetamine and other high-risk medicines like ketamine and quetiapine. So all of these medicines, if they've been supplied for someone in the past 90 days, they'll be on the person's history in SafeScript. And also if you're prescribing any of these medicines or dispensing them in a pharmacy, you're required to check that person's history. Most of the time, SafeScript will be integrated with prescribing or dispensing software, so it's relatively easy to get that information, but it is an extra step. If there is anything in the system that suggests that there's an alert, so for example, if someone's on a particularly high dose of opioids, if they're on particular medicine combinations, or if they've been seeing multiple prescribers, you'll get an alert in the system that you'll have to go in and see what information is sitting behind that alert. And then whoever is either prescribing or dispensing the medicine will use that information to decide what they're going to do next. those alerts absolutely do not mean that medicines can't be supplied. So SafeScript isn't a policing tool. It doesn't tell people that they can't prescribe a medicine, but it does give them that information. We do hear a little bit about sometimes people misinterpreting the information and maybe saying they can't do it because there's an alert, and there is a lot of education ongoing about that. And we do often see that sometimes depending on a patient's history that this might lead to some treatment referral. So we might see people starting to come in contact with the alcohol and drug treatment system because SafeScript has flagged that they've got escalating or perhaps a risky pattern of medication use that warrants some additional sort of drug and alcohol treatment.
Susie, I think we might have to.
That's my last slide. So
have you got much more? Oh, you're finishing anyway. Sorry, I was just became really aware of the time. Yeah, I'm aware there are, I think, some online questions. We're not going to have time to do it as a Q&A live. Are you able to type?
Yeah, I can type some questions in there while the next speaker's going.
Yeah, that would be brilliant if you could do.
No problem.
Thank you so much for coming and talking to us. I guess it shows us just how complex a lot of this area is, and your knowledge, has been really invaluable. Okay, so thank you again. Okay, our next speaker is Casey Elmore. Casey is the Operations Manager of Australia's second medically supervised injecting room, working on the design, development and implementation of the facility. She has worked in the AOD sector for more than 15 years, primarily responding to overdoses in community setting. Casey has contributed to harm reduction programs internationally, including consulting and implementing Belgium's national naloxone program. She is both committed and proud to be part of the global harm reduction community. Welcome, Casey. You're on mute, Casey. I've just done
my space bar's not working like I'd like it to. Thank you for having me. I'd like to start by acknowledging the traditional owners of the land on which we all meet, and extend my respect. I'm just here to talk a little bit about the medically supervised injecting room. I am trying to share the slides, but Jane, if that isn't working, can I get you to do that from your end? Is that? You're on mute too.
Sorry. Your mouse is working. So if you come up to slideshow up here.
Yep, got it.
Yep, click on that.
Got it. Thank you.
And it should, yeah. There we go.
Thank you. All right, the first question everybody kind of asked, and I'm not sure, forgive me, I'm not sure how much who's present and the knowledge that they also have. So a good place is always to start, how did this happen? Why did it happen? Why Richmond? And I'll do my best to be able to give an overview. So I've worked at North Richmond Community Health, so in the local Richmond area for over 15 years now. Predominantly my role was responding to overdoses out in the community. And I think only now I can really reflect back on some of that time and realise the actual impact of substance use and a street-based drug market, both on people working in the community, definitely on the clients themselves, residents, traders. So I think there's many different aspects in which one could look at from this, but for me predominantly it was always the effects on the clients and also what was happening, but not to say that one particular key stakeholder is more important than the other, but that was my primary focus. So in 2017 there'd been a significant, and probably to the end of, well, in a 12-month period, so 2016 2017 there were 34 deaths in a 12-month period. I never kind of get caught up in numbers too much, to be honest, because for me, one death's too many. And I know that kind of sounds a little bit cliche at times, but really it is. And the people that we were working with and responding to on the streets, we're talking about visible deaths in the community. They're occurring in public car parks. They're occurring on footpaths. They're occurring in alleyways, laneways, and it was just horrible. And it had a major impact on the lives of people who came to Richmond, who were using drugs in Richmond, their loved ones, their family, their friends, residents, workers, like I said, and traders, and it was really important. So along with the fatal overdoses also comes amenity issues, whether or not we like to acknowledge that or not. So there's public injecting that goes along with that. There's discarded injecting equipment that can go along with that. And there's also some behavioural challenges too, along with dealing. So this is just a slide. I think over time, the media, it felt like every couple of times a year, we'd be in the media at some stage highlighting drug-related issues in the local area. So this was just a little bit of a snapshot. So really, I guess, what was most concerning is the 34 very public deaths that occurred within a 12-month period was, I guess, the catalyst. And I think before I move on to the other slides, I think what's really important as well is not only were there these issues and impacts on the whole community more broadly, but I guess it didn't work like this happens through advocacy as well. And it's not just one or two people advocating. This was a strong advocacy campaign. It wasn't often coordinated. It was different times by different people around different areas. But it's people have long been advocating for this. So I think I too like to often acknowledge the hard work, because these are people that we don't even know what kind of advocacy or what role they've played in part of this. But hundreds of people, I imagine. So they're a really important part of also why we have an injecting room. So at the tail end, when it was recognised there were the 34 deaths within a 12-month period, what was really interesting to me, which I hadn't seen until this point, particularly seen and heard, were the community banding together to say, we don't want this happening in our community anymore, particularly around fatal overdoses that are definitely preventable. And marches happened, and it was powerful. And we hadn't, I think, up until that point, you'd have conversations with community who might have engaged you, privately on outreach at times. But these guys banded together, which was just incredible, which we hadn't really seen until this point. So there's some photos, which brings me to this mural. And behind this mural is a collective of local residents, which is the Victoria Street Drug Solution Group. They, without a doubt, did a lot of work and a lot of advocacy, door knocking to other residents. They did a lot of media appearances, and they created this mural. You'll often see other posters and things pop up that Victoria Street Drug Solutions are also behind. So that it's just been incredible. So why do we have it? We now have an injecting room because a lot of the area needed one. It was deemed that there were these deaths that were occurring in community because they were preventable. Many amenity issues attached to that also, but also overwhelming advocacy provided by hundreds of people over a period of time as well. So late 2017, in the background, and I'm not sure if you guys can see, so this is Premier Dan Andrews with Fiona Patten, who was responsible for introducing the bill to amend legislation, Martin Foley, and a few other key people. Ambulance Victoria present, Victoria Police, Richard Wynne's in the back as well. So an announcement took place at North Richmond Community Health to say that they would be trialling a two-year trial of a medically supervised injecting room at North Richmond Community Health. So at that point in time, there was an acknowledgement that the organisation was very close to a lot of drug-related activity and overdoses, and also had wraparound support services that could also be used, that also had been used, that clients were linking into as well. So the MSIR, affectionately known, the Medically Supervised Injecting Room, began planning. So there was some objects of the bill, objectives that we knew. Part of a trial, you're being measured throughout the trial to see if you'll extend and see the validity, and I think that's obviously good practice. So here's the things that I don't know if it's worth reading, but you know, to reduce the number of deaths, to deliver more effective health services, ambulance attendances, amenity issues, discarded needles and syringes, and also assist in reducing bloodborne viruses. So they're the things that were the objects of the bill in which that were introduced, and also part of the evaluation that we needed to address as well. So, boy, it was a very short, but between the the Premier's announcement and us opening our doors was a 7-month period. So in that time, we were very busy getting a lot of things ready because we weren't quite prepared for this. So we opened our doors in a transitional facility on the 30th of June 2018. And in that period of time, we designed 2 facilities. We designed this transitional facility that you'll see on your screen. We designed a purpose-built facility as well. There was building going on at the times. We designed the model, literally the model of care. We had to create a database. We had to write all the policy involved. We had to employ the staff. We had to train the staff. And this was all kind of without having run a facility like this before. And obviously we have an amazing, we'll call it a mother facility in Sydney, the MSIC, the Medically Supervised Injecting Centre, who really supported us throughout. There's no way we could have got this up and running without the support of MSIC. And even to the point when we first started, because none of our staff had worked in a facility before, we had one person actually that had come from Sydney at that time. So Sydney helped us for the first month by providing us with staff to show our staff how to operate a facility as well. So it was just incredible. And I think the other thing that we did is we visited, we spent some time in Sydney, but we spent some time overseas looking at the models and looking at what worked well for people, what they would change if they had to do it all over again, and kind of learn from that process, as well as speaking to our clients. We had spent some time leading up to this around questioning what they were wanting from a service. We used part of our knowledge. There's been staff at North Richmond for a number of decades who'd been providing service to the clients for a really long time as well. So getting their input as well. And then we had one large day, which we held a World Cafe. So it was a bit of a rotating question desk day, and I think we had over 50 clients attend and provide us with input about what they wanted from a service. No surprises. There were a lot of the feedback we had was relating to some of those wraparound support services that people wanted. So I think what we acknowledged very quickly is that clients, most of the clients who'd overdosed and that they were able to be resuscitated, when talking to those individuals, there was not a desire to die as such, but this was a common theme. I have to say, throughout 10 years or so that I was actually part of that overdose response. So not a desire to die, but I guess an exhaustion of their substance use and the effects that it had on their lives and their health. And so it was a really common theme to hear some of these things, and looking at overdose more broadly, it gave us an opportunity to really look at overdose as not just witnessing somebody inject, although that's incredibly important to be able to intervene quickly, but looking at those other contributing factors to overdose as well. And that's what we hoped to achieve. So the transitional facility did exist in the main building of North Richmond Community Health, and it had capacity of 11 booths. It was quite small. So it had an entry section where people would come and register. An injecting an injecting zone, and it had a medical monitoring area, a very small consulting room, and an aftercare area in which you could monitor people post injection, and also link them in with some support services that we had on site at the time. So when we got to visit some of the other places globally, most of the models existed like this. It was a staged 1, 2, 3 approach. It was linear. You go in, you go through that system, and you go out. And I think what was highlighted to us on more than one occasion is the challenges that the linear model has. And the first one is it is designed for throughput. So people are going in and out, and you want people to go in and leave quite quickly so more people can come in, depending on, I guess, the client need. And we knew that the need in our area was really large. So that was problematic. And what was also identified through other agencies and organisations who ran facilities with a linear model was the fact that for clients who wanted to participate in group activities or see a doctor or visit some kind of social support service, there generally had to be an injecting episode for them to be able to do so. So can't really encourage that backdoor flow through the other way. So that was interesting for me. So we were looking at all these things when we were looking at building our purpose-built facility as well. So that brings me to the 4-stage model that we came up with, that we would hope to accommodate some of those things. So I'll use my mouse. So the entry zones here, and it exists, it's got a needle syringe program as part of it. So people, as far as client flow goes, people can come in, access the needle syringe program, and then leave if they choose to. They can also come in and say, oh, I'd like to see the doctor or housing or legal or podiatry, and they can go straight into this red section. It's the consulting area. That's got 3 rooms, 1, 2, 3. And the other client pathway is to enter, register to use the injecting room. The blue area is the injecting zone. The middle section here is the staff room, the staff office. So I'll come back to here. This is the injecting zone. This is a medical monitoring room where we, most of the overdoses we manage are done so at the booths. And we move people who are more sedated into this space. Given our current COVID environment, we'll also move people into this medical monitoring for, I guess, more significant medical intervention that might release aerosol as well. Once somebody's injected, they then go through this section here, which is the aftercare. So there's a treatment room attached here as well. There's aftercare here. So at this point in time, clients have 2 options. So they can choose to leave out here and say, that's enough for me, I've just come to inject, off I go. Or if they want to, they can go up back here into the consulting area to be linked in if they identify they'd like to see the dental or doctor or what other services we might have on at that point in time. So it was really important for us to provide choice and opportunity, and not force people to feel like that they need to take on a treatment that they don't want to take on. So that was, choice is really important. And then we have a group space here. Unfortunately, we can't use that currently because of COVID. So that's our current purpose-built facility. We moved into that facility just over a year after being in the temporary facility. So the 7th of July 2019 is when we moved into this facility. All going well. This next slide is a 3-minute video. And fingers are crossed.
Casey, yeah, my only concern is we are literally right on 3:30.
Ah, all right. I'm happy to pick it up.
I'm just wondering if we can make that video available.
We sure can. I think is it okay if I just say what's really important too that people are most curious about? All of this is available. I think it's probably the other information I was going to provide can be found online. The Hamilton, we had an independent review provided by Margaret Hamilton and Co. It's online for people that are interested, and it talks about our statistics. So
Yep.
people are very curious about that. So it is online that people can find.
Yep. Okay. All right. Well, I mean, maybe if you could say email me or James the details, and we will make sure that that goes out with, to all the participants.
Sure. Answer any questions, sorry.
Yeah, I think we've run out of time. I think,
Yeah.
there's so much to cover, and look, thank you so much for coming on and talking about that, Casey, because I think it's,
Welcome.
yeah, it's been a subject that, obviously gets quite a bit of coverage in the media and things like that. And I think it's important for people to realise that, a whole lot more work has gone on behind the scenes that people don't know about, and, all the really good work that the ejecting room does. So on that note, I will hand you back to James, and he's just going to do a wind up. Thank you.
Thanks.
Thanks, Jane, and thanks, Moses, Susie and Casey. And thanks everyone for coming today. It's been a great webinar and a great overview of the AOD service system and various components of it. The AOD system does do such important work, but it can be very, very difficult to navigate for both its clients and for other people who interact with the service system in their work or for their family members or anything. So I think this is just really, really important. I'd like to remind everyone to please complete the survey. It will be available once the webinar finishes. It'll come up on your browser. And you'll also receive an email tomorrow about it. We do really appreciate everyone who completes that. Next Tuesday is part 2 of AOD 101. So we have 2 great speakers for you next Tuesday. Olivia Nichols from Odyssey House, and we're also going to hear a consumer perspective from Kit. So we're really looking forward to seeing you there. And thanks again to all our presenters. It was really fantastic.